I'm going to move on. So, intubation. This is relevant. Now, if you work in a setting, this is not going to be of any relevance to you. I won't be offended if you disappear right now. But if you work somewhere where this could happen, either by your hand, either by you being around it, or quite possibly, you're going to have somebody retrieved out of your hospital by RFDS or the chopper, and they are going to intubate in your department. And if that could possibly happen, then you want to be listening to this, because you will be potentially part of all of this and exposed to all the aerosols if this is not done properly. So this is important if you could ever be involved in this, in and around this process. This is the highest risk AGP. This is a recipe for COVID if you don't do it well. So what have we done in other hospitals? And this is not necessarily possible everywhere. I'm just going to tell you what we strive to do, and you may or may not be able to apply this in your center. So we've actually given up intubating to the most capable intubator in our place. And the other thing is, you got to train on this. Now, if you're going to intubate patients with COVID, there's so many modifications you're going to make. You need to train and simulate on this. And that can be easy if you've just got one group of people training and simulating on it all the time. So at both, at all the hospitals I work at, actually, we've relinquished this to the anaesthetists to be the intubators in the intubation team, and they will come down for COVID patients or suspected COVID patients, and we as ED consultants will be the team leader and run the intubation. But so for your settings, if you're in the wheat belt, it might be, if you can't intubate, that most capable intubator might be RFDS when they rock up, and your job is keeping the patient alive until they get there. And I'll just kind of mention, there are going to be lots of suboptimal situations in everything we do here. You might have to put somebody on high flow. No, you don't have them. You might have to put someone on CPAP, and they may have mask leak. You may have a standalone CPAP machine and nothing else, and the patient sat at 70% on room air, on a non-room breather, and RFDS are 4 hours away. And you have to choose between non-closed circuit CPAP, which is going to aerosolize to the room, or the patient is going to die. And you're going to have, these are choices that we're all going to have to make. And similarly, when we talk about intubation, we would love to not bag this patient at all. And we love to not use suction at all. But there are going to be patients, if we don't, we're not going to be able to intubate them. Their sets are going to plummet and they're going to die. And so the hard decision-making here is whether what you're prepared to do as a clinician to intervene to save the life of that patient that might actually give you COVID. And that's a big decision, because if you get COVID, that loses a healthcare worker, and that can affect a lot of patients. Even just for the couple of weeks you might be out, or of course you could die, right? So there's lots of death here that we have to balance up. And so these are difficult decisions for everybody, and I'm not here to tell you what to do. You can decide what you wish to decide for your individual patient and take advice, but ultimately it's your choice, and staff safety comes first. And it's tricky. It's a tricky situation, but that's kind of the main thing I want to say is, and the decisions will be different for different patients. If this patient's 85, then there's a very strong chance you may choose not to do those things and palliate. But if the patient's 30, you may make different decisions, and it's entirely up to you. And this is COVID. If this was Ebola, you might make different decisions again, right? Because, you're more likely to die from Ebola. So lots of things to think about. And I have no easy answers. I can only give you things to think about. So let's talk about intubation. Some of the modifications we're going to make. So why don't we start bringing some equipment in and start talking about this? So we're going to, we want to use the most capable intubator that you can have. We want to use video, and we want to kind of do a lot of planning and things outside of the room. So I'm going to stop the share. We'll come to these in a second. Ooh. Okay, so I think I've stopped the share. That's right. So some of the things we're going to do is we're going to use the video, and the reason we're going to use the video is because, one, it probably improves your likelihood of intubating the patient, and two, when you intubate with a video, you can actually keep quite far. When you put it in, you can actually keep quite far away from the patient, look at the video, and pass your bougie and tube or whatever you're going to use, But when you're actually not using video and doing direct, you have to get much closer to get a proper view of the airway. So for staff safety, video is king if you've got one. If you don't, we're not going to use video.
So Northern has a video laryngoscope. Narrowden's got a version of the video laryngoscope.
So the AP Advanced is what a few places have.
Oh yeah, who else has the AP Advanced?
Narrowden. And
Narrowden?
Narrowden has
Okay, cool. I mean, most likely intubation would happen at Narrowden or Northern, I would think.
Yeah.
And outside of those centres, you're going to be waiting for, RDS for someone to rock up and using some other measure to keep the patient alive if you can, and if it's safe enough to do so. The other thing we're going to do is we prepare everything outside the room. So a lot of places will have some sort of intubation pack or box or something for COVID that's got all the essential stuff that you need to take into the room, ready to go. And you'll either take that whole box in, or you'll lay it out on your on a trolley and go through your intubation checklist, which we'll do in a second, to make sure you've got everything. A preceding statement is a statement you've probably heard a few times, but there is no emergency in a pandemic. And what that means is nothing is done quickly in a pandemic. And, you have to follow all your processes and do everything and check every single box before you walk into the room, for example, with an intubation. But with anything, when you're donning and doffing to see any patient, you do everything at the speed that it takes and you don't rush it. And that sometimes means there will be some patients who might have an adverse outcome because of that, but staff safety is paramount. So we prepare all our things, but there are some things that you might need. Let's say we're using the CMAC, and we've got another blade called the hyperangulated D blade, which we use in emergencies when we can't get a good view. Where most places wouldn't, or some places would, some places wouldn't take that into the room because it needs to be cleaned and all the stuff afterwards. Whereas we can leave it out the room, we can reuse it without cleaning it. So a lot of the kind of emergency equipment like cricothyrotomy and D blades, other things, are kept just outside the room with a runner to bring it into you if you need it in an emergency. So that's a bit about the equipment. Any other things you can think of?
We've got all that in a box.
So you've actually got them drawn up already?
We don't have them drawn up. I have been toying with that idea. But so we've got, the basic drugs that we're likely to use in a box. Yeah. So
some people have got their drugs already. Like, I don't know, other hospitals they've got the full drugs, in a box. That they bring that to the intubation and then draw up there. And so they already decide what the drugs will be, and they bring them in. What drugs to use while we're on the topic? So up to you. But for paralytic, sucks or rock. If you're going to use sucks, use 1.5 to 2 mg per kilo. Like, use high doses. If you're going to use rock, use high doses. And most people these days are talking about 1.5 mg per kilo of rock, because you want rapid paralysis and basically zero chance of them coughing at any point. And there is a bit of debate between sucks and rock. I don't know if we should bother getting into it. Drugs wise, I think ketamine.
Rock, and the paralysis, wait a whole minute.
Yeah, so it's at least 45 seconds. For rock, at those doses. Whereas with sucks, you can kind of rely on fasciculations to some extent. But so you've got this long acme period, and we'll talk about that being a nuisance and what to do about that. But for your sedation drug, probably ketamine is the best to take into the room. If you're taking one drug in the room, ketamine. And the reason for that is, if you try and pre-oxygenate your patient, and you're going to pre-oxygenate usually with the BBM, the other option is the Mapleton C, but most people in ED never use the Mapleton C. And again, don't try anything new in a pandemic, right? So use the BBM, and we're going to hold that on the patient's face for pre-oxygenation. Some patients who are hypoxic won't tolerate this. They'll be confused and will want to knock this away, but they have to have this and get pre-oxygenated, which means you give them ketamine first as a delayed sequence intubation, DSI. If you don't know what that is, just Google it. But you're basically giving them ketamine for procedural sedation so that they can actually do the pre-oxygenation properly, and then you paralyze them and intubate them. So that's why I think ketamine is the preferred drug, or at least take it into the room with your other drug.
So we do have ketamine in the drug kit, the COVID drug kit.
And then I've got some other modifications. I'll just go back to the PowerPoint. Minimize the people in the room, right? So you I would say a maximum of 3 in the room. In the Safe Airway Society, they just give an optional 4th, but everywhere I'm working, they're just having 3. And so I know now some anaesthetists are happy just to do them and their tech, but I think the 3rd person is really important. So, and the 3 people are the intubator, the airway assistant, and the 3rd person is the person who's a team leader with situational awareness, who goes through the checklists, who checks every point, who gives the drugs and does everything else. And that's usually the most senior person other than the intubator, in the room doing that. Talked about drugs. Now, BVM, you have to use a 2-handed technique, even if you think you're amazing with one hand. If you can hold the other bit. It's been shown in evidence that everybody who's amazing with one hand is more amazing with 2 hands. And I'm just talking about face mask oxygenation. So if you use 2 hands, you've got slides on?
We can't see. They can't see because
right.
there's PowerPoint's on.
Good point. Very good point. It's good to have helpers. So if you use 2 hands, I generally recommend the 2 thumbs down approach, which is as advertised, 2 thumbs down, with the meat of your hands on the mask and your big strong fingers doing your jaw thrust, etc. And absolutely doing your best to minimize the leak with 2 hands. You're the person who controls the mask. You're also the person who will decide if you want to increase or decrease PEEP, and the other person ventilates usually. And so, in fact, actually, no, that person should actually increase and decrease PEEP. You can just keep your hands on the mask. So PEEP is given by a PEEP valve. PEEP valves are on pretty much, they're all on the wheel.
Well, I'm not entirely sure.
They've been ordered, but I don't know if it's actually
right. Okay, so if you haven't got one, contact Anna later, because you should have one.
Rioc.
Yeah, it's not her fault, but she can facilitate. So PEEP valves allow you to dial up PEEP to whatever you want your PEEP to be on the PEEP valve, and they just go onto the normal breather mask. So, and you need this because these people are going to be hypoxic, and they need an extra PEEP to open up the airways to get their sats to something reasonable before you intubate them, and they might drop like a stone during your process. So you also need to have. See, a lot of you would recognize this. This has been your normal setup, right? So we've added a few things. 1, you have to have the PEEP valve on the expiratory port. 2, you have to have a valve, the filter, which we talked about, connected to the mask, the viral filter to protect everybody. So it's only the air that leaks that's going to put you in danger. Everything that goes through here, you're safe. And 3, ideally, you want your CO2 on there as well. So that means that while you're pre-oxygenating, and if you do have to ventilate them, you get feedback with the CO2 trace to tell you, I'm doing a good job. Whereas if the CO2 trace is not a good trace, or your numbers are low, it suggests you've got a lot of leak and you need to improve your seal, because otherwise you're going to aerosolize to yourself. So this is the ideal, and that's a lot of stuff, but you need to have all this stuff on. And that's why you need another person partly just to hold the weight of it. So that's, what we recommend for BVM technique. And then I'll just quickly see. Now the idea, the theoretical idea, is that you don't bag, right? You never actually bag the patient in that long apneic period while you're waiting for the paralytics to work. But unfortunately, with all these patients, they sats drop like a stone, and then you have to choose between cardiac arrest and bagging the patient. So again, difficult choice. One of my colleagues said, well, if they arrest and I'm going to have to start doing CPR and stuff, that's going to be more aerosol generating and much more messy than me simply having a 2-handed technique and giving a couple of breaths. Good point. And so, you choose again. But those, ideally don't bag if you can avoid it, but you may have to. And if you can't intubate and they start to dropping, you often may need to bag. And so try and do it as safely as you can. Apnea oxygenation. Normally we would put nasal prongs on for every single ED intubation because it helps maintain your oxygenation while the patient's not breathing. But 2 things. 1, it's effectively highest flows of cannulas, like 10 to 15 liters, and it might aerosolize right in front of your face when you're above the patient. And 2, there was a trial in 2016 that looked at using apnea oxygenation in sick ICU patients who had collapsed alveoli and needed to be intubated, and it didn't seem to help. So in these patients, it might not help, and it probably does expose you to risks. So as a result, pretty much everybody agrees that we don't use it with these patients. So don't put the nasal prongs on. Again, avoid suction if it's not necessary. If you can get a view without suctioning, don't, because suctioning creates aerosols. As it suctions, not everything goes through the suction and comes out in the air. So don't suction. But again, if you can't see anything, you're going to have to choose between whether you intubate or not, or the patient dies. So another one of those difficult decisions. And you may need to choose to suction. And then post-intubation, do not bag or ventilate them until you've inflated the cuff. Until you've inflated the cuff, you do not have a seal. And so you are just going to aerosolize stuff to your room. So inflate the cuff, then test that it's working. And when you test that it's working, that you've intubated them properly, you don't listen to their chest, because that's high risk. You just look for CO2 trace, misting, and when you're putting your tube in, look for the black markers lining up with the cords. And later, if you get one, a chest X-ray. But we're not actually listening to the chest anymore for COVID patients when you're intubating. And some centers are immediately connecting. So as soon as they intubate, they are connecting straight to the ventilator and not bagging at all. But that can be difficult to do depending on your inline suction setup and your CO2 setup. Can actually be tricky. So the scenario we're going to go through here is that we can't do that easily with our CO2 that we've got. If you've got inline CO2, it basically makes it impossible to do this well. So let's just go through it now. Yeah. You got it set up, you good?
Yeah. So we'll do it from this.
So let's stop the share. Well, this bit we'll just talk through, and then we'll just.
Oh.
Yeah. So we'll just talk through this bit. Right, so how to connect this up?
Yeah. Okay, yeah.
Okay, so this is, I've been, pre-oxygenated patient. I try to intubate. Let's say I don't succeed. I may have had to bag them possibly with somebody else bagging while I've got two hands on. But hopefully I do succeed. And then I've got the tube in. So tubes into the patient. So you hold the tube, and we now need to, confirm that they've actually been intubated correctly, breathe for them, and get them onto the ventilator. Now, one option is to go straight to the ventilator, but you'll see that there are a number of reasons. It's hard to do when you've got inline CO2. So what we'll probably do is connect directly onto the ET, right? But after we've already blown up the cuff and the ET, right? And you've got a secure cuff. Then we're going to bag, right? So we've got our filter still on, CO2, everything's there. So bag, and so that's one of the reasons for having this all set up, is that now straight away we've got everything set up as we need it as soon as we've intubated. And then, we can see a nice CO2 trace, fantastic, great. Can we tie that tube in? Fantastic. Now, we are going to connect them onto the ventilator. This is a planned disconnection, and that's going to involve clamping the tube. Whenever you disconnect, you've got to clamp the tube so COVID doesn't come up the tube. And now we are going to take all of it off. So everything off the ET tube, and connect a second set of stuff. So second CO2, a second filter, and imagine you have inline suction. We don't have it yet in the wheat belt, but you'd have inline suction here, right? Also on order.
It is, yeah.
And so imagine this is inline suction, already suction, filter, CO2, a second CO2, a second filter, and then connect that straight to the tube. And then connect up our second CO2 to the monitor, and then start your ventilation up and unclamp your tube. So that is the process to safely get them onto the ventilator. If you don't have inline CO2 and you've actually got side stream CO2 that hooks onto your filter, it's an actually easier process.
Narrowgen
and Narrowgen apparently have that. But when you're inline CO2, it's actually a bit more difficult. And what we've done, I think, is probably optimal when you've got inline CO2. So that's the main modifications. We're going to go through. I'll just see if I've got anything else to say here. A colleague of mine who's an expert in this area highly recommends kind of securing connections that are liable to accidental disconnection. So, I'll just come off that. Yes. So, because what they've happened in America and stuff is that they've everything's done, they've intubated, and they're like, yay, and then they are transporting the patient on to be ED to the ICU or whatever, and something disconnects and they just get COVID everywhere. So, so places in your circuit that could get disconnected, like between, so, you've got your tube and your patient, you've got this, suction, you might want a tegaderm between your tube and here. You might want to tegaderm potentially between these, or some tape or something between here and the filter, across here. These are all places that any one of these places can disconnect, and that's a disaster for everybody. So you may wish to choose to secure them in some way, in ways that we would normally not do, because we normally don't really care if it gets disconnected for very long.